Shortly, I would like to say that we've heard from the fire marshal, and he would like everybody to be seated. If you have to stand, we have overflow in room 181 with a TV and sound. So I will call the joint meeting together, and the reason we're doing this meeting is to help the department, instead of doing 4 different presentations on this, to try to do it in one presentation. And this has to do with the Federal Reform Act in Washington. And like it or don't like it, it's the federal law. And what I do know is that all the polling shows nationally that people have mixed opinions about the Affordable Care Act. But if it goes forward, which it will, they would love that the states do it themselves and be in charge of their own health care system. So we're going to go forward and try to be as bipartisan as we can and get a bill that meets the federal criteria but still recognizes that the health care system in Minnesota is much different than most of the rest of the country. Normally we do introductions, but that could be 40 different people, so I think we'll skip that tonight and invite Scott Leitz right down to start. And Assistant Commissioner Leitz was in Washington, D.C. on Friday, I believe, talking about this very thing.
Thank you, Mr. Chair. Mr. Chair, members of the committee, my name is Scott Leitz. I'm the member of the committees, I guess, actually, in this case. My name is Scott Leitz. I'm the Assistant Commissioner for Healthcare at the Department of Human Services. Pleased to be here tonight. I'm going to try to give an overview of a not very modest topic, which is the Affordable Care Act. And there's a lot of provisions that are included in the Affordable Care Act. What I'll be really focusing my remarks and information on tonight are around the Medicaid components. There's obviously components in the bill that relate to health insurance exchanges, relate to public health initiatives. I'll touch on those things that are germane to Medicaid, so I'll talk a little bit about the exchanges, but really this will be primarily focused on the Medicaid aspects of it. As an overview, just so you know what's in front of you, I'll give a little bit of background on Medicaid and Minnesota's healthcare programs, just so you have a little bit of grounding on the programs that we currently operate in the state to provide health insurance coverage to Minnesotans. I'll touch on what some of the provisions are in the Affordable Care Act, and then talk about how the Affordable Care Act impacts on Medicaid. There are some fairly large things that are in there that are required of the state to do to comply with the law, and some things where the state's going to have to make some decisions. And I want to talk a little bit about so that you understand what those are and what options are in front of the state. So I'm going to move into this and just start to begin talking a little bit about the programs that we currently operate. We operate 2 primary healthcare programs. One is medical assistance, or the Medicaid program. Medicaid is coverage for individuals. I'll get into more depth on this in a second, but we cover about 768,000 people through the state's Medicaid program. We also operate a program called Minnesota Care, which is a subsidized health insurance program where people pay premiums for coverage that's roughly equivalent to Medicaid coverage. We enroll about 127,000 people in the Minnesota Care program. And then Medicaid also serves as a supplement to the Medicare program. There's some cost-sharing elements in the Medicare program that lower-income seniors frequently have difficulty meeting. The Medicaid program serves as a supplement to that program for elderly Minnesotans who need assistance with their cost-sharing. We operate these programs in partnership with the federal government, and in Minnesota, every state receives assistance in some financial way from the federal government. ranging from half of the cost of the program up through higher levels in lower income states. In Minnesota, both of our programs, Medicaid and Minnesota Care, do receive federal financial participation, meaning that the cost of the program is split between Minnesota and the federal government. And generally in Minnesota, that means we pay about half the bill and the federal government pays about half the bill for our programs. So I'm going to move now and talk a little bit more specifically about the Medicaid program. As I mentioned, Medicaid is a public health care program for individuals and families with low incomes. It's jointly funded and jointly regulated by the state and by the federal governments. Largely this works with the federal government setting forth broad categories of guidelines, and then states having some flexibility under those guidelines to establish there's certain required eligibility levels, and then states have some ability to set optional eligibility levels, as well as from a benefit perspective and a payment perspective. So you can think about it as an overarching federal framework with states able to have some leeway underneath that general framework. And the federal matching assistance percentage, or what's called FMAP, it's an acronym you might hear moving forward, is the percentage of federal funding a state receives for its Medicaid program. And as I mentioned earlier, in Minnesota, that generally is half the cost of the program. Federal law does require state Medicaid programs to cover certain categories of individuals and certain services underneath that. Beyond that, the states do have some flexibility in the design and implementation of the Medicaid programs that they operate. As I mentioned earlier, in Minnesota, we call our Medicaid program medical assistance. And as I mentioned earlier, the Minnesota Care program is also technically a Medicaid program because we operate that program under a federal waiver of Medicaid rules that allows us to receive federal matching funds for populations that typically otherwise would not have received traditionally federal Medicaid matching funds. In terms of financing, the medical assistance program is funded through a combination of things. It's really state payments from the general fund. There's a general fund funded program. As well as funding from the federal government for under the Medicaid and CHIP program. And the populations that we receive, that we enroll in Medicaid are listed here. They're children under 18 up to 150% of the federal poverty guidelines, kids who are 19 and 20 up to 100 up to the poverty level, pregnant women up to 275% of poverty, parents who are below poverty, and then individuals who are older, blind, or disabled below the poverty level. And then effective March of 2011, we were one of the states that opted into expansion under the Medicaid program that was allowed for under the Affordable Care Act starting March of 2011. That's for individuals who are below 75% of poverty. And that expansion effectively replaced what had been the General Assistance Medical Care Program that operated in Minnesota for a number of years. In terms of enrollment, I won't read through these figures. The only thing I'll point out on this slide is we have about 768,000 total individuals. You can see how they're divided up. A little more than half of the enrollment is families with children. That's also our least expensive population, costing about a little less than $5,000 per capita. Obviously, the elderly disabled, who are a smaller proportion of the enrollment, but have the highest per capita cost because their needs are the highest. They're disabled individuals, older individuals. And then adults without children, which we expanded under the opportunity of early expansion in the Medicaid program, are somewhere in the middle in terms of cost.
Scott, do you want to talk about that population, the GAMC, and what their real incomes are and their health status?
Mr. Chair, in Minnesota for a number of years operated a program called General Assistance Medical Care, and it was really targeted towards very, very low income single adult individuals. These are folks with incomes below the poverty line, in fact, below 75% of the poverty line, so very, very poor people. The characteristics of a general assistance medical care enrollee was typically folks who had health conditions, chronic health conditions, frequently coexisting mental health conditions. They were obviously had very low income, so likely were not employed. and frequently had some substance abuse and chemical dependency issues as well. So these are folks who had multiple things going on in their lives with very, very low incomes. Hospitals typically care for these people, and they show up episodically. GAMC was put in place to provide some form of reimbursement for the services that were delivered to these individuals, as well as to try to get them into some form of a health insurance coverage. What the when the General Assistance Medical Care Program was eliminated several years ago, it was replaced by a program called the Coordinated Care Delivery System, or the CCDS model. That was a relatively short-lived model that was replaced in March, and that was kind of a block-granted program to hospitals to cover the cost of services. It didn't fully cover the cost of those services. When we did, in March of 2011, the Medicaid expansion to that population, what it brought to them was a more complete benefit set, as well as a shared federal financing for the costs of those individuals. So we think it was the right step to actually put in place to get those folks into more stable coverage, as well as bring in some participation with the federal government on coverage for those individuals. Turning to Minnesota Care, again, this is a program that was established back in 1992. In fact, just celebrated its 20th birthday as a program operating in Minnesota. And it was a program that was put in place because there were individuals who sort of fell in between. And what I mean by that is they had incomes that were too high for our state Medicaid program, but they didn't have job-based health insurance coverage, which is where the vast majority of us get our health insurance coverage. And so it was a program for those folks who just didn't have access to that affordable coverage. But it was structured in a way that was structured a little bit differently than Medicaid, in that people were typically working individuals. They were families primarily, and they pay a premium to be on the program, a sliding scale premium, so that there was an expectation that they were also putting out contributing towards the cost of their care. The premiums in the program are based on income, and it's done on a sliding scale. And the financing for this program is a little bit different than it is for the Medicaid program. Minnesota Care is funded through a combination of state payments from what's called the Healthcare Access Fund. The Healthcare Access Fund is the fund that was created also in 1992 and is funded with a 2% tax on gross revenues from healthcare providers, and a 1% tax on HMOs and nonprofit health plan corporations. So it's a fund that draws that in. It's also funded from the premiums that individuals pay in the program. And we negotiated back in the 1990s to receive federal participation under what's called our prepaid medical assistance or PMAP plus waiver that allows us to draw down federal matching funds on this program. The program does go up a little bit higher in income, because remember, this is a program that was intended to sort of fill the gap between Medicaid and job-based coverage. So children are eligible under this program up to $275 of poverty, pregnant women also up to $275, parents up to $275, and then adults without kids are eligible up to 200% of poverty. There are some Minnesota Care populations that are fully state funded. The first being the individuals enrolled in the Minnesota Healthy Contribution Program. This is a program that was established about a year ago to provide subsidies to individuals to purchase coverage in the private insurance market. So these are folks who were previously eligible for Minnesota Care. We moved them into this program about a year ago, and they're able to get subsidies to pay for private coverage. Lawfully present non-citizens who do not qualify for federal funding due to their immigration status. These are typically folks who have resided in the U.S. for less than 5 years. They aren't eligible for federally funded Minnesota Care for the first 5 years that they're here, but they're here lawfully. And then legal guardians and foster parents. Just in terms of cost, real briefly, you can see what the costs are for the program. It runs for fiscal 14. We have about 127,000 individuals enrolled in Minnesota Care. Families with children, obviously a little bit less expensive, again, similar, mirroring what we saw in Medicaid, and adults without kids a little bit more expensive. Total cost for the program, a little over $600 million expected. So, Mr. Chair, that's the sort of a backdrop of kind of our programs very broadly that we operate. With that, I'll move into some discussion a little bit more specifically about the provisions that are going to be impacting Minnesota and the Medicaid program moving forward as we implement the Affordable Care Act. Generally speaking, I thought it'd be useful just to give you what the framework is for the Affordable Care Act, because it kind of hits on what some of the elements are that we'll need to think about how we want to implement within Minnesota. There is a requirement, as everybody knows, for individuals to have health insurance coverage. This was ruled on this past summer, and the Supreme Court did rule that that was a constitutional provision. It does have the establishment of health insurance exchanges with subsidies for individuals to purchase coverage. I'll have a slide in a second that talks about kind of how that intersects with Medicaid. There's opportunities for states to expand Medicaid coverage to help people meet their requirements to have coverage. But one of the things that the law very explicitly lays out is that one of the things that we've built over time, and every state has built, is a sort of a patchwork of programs that have been put in place to try to provide coverage to individuals. And it can be difficult for individuals to sometimes navigate through those programs. And what we would like to build moving forward is a much more seamless way for individuals to both get into health insurance coverage, whether that's through the exchange or if they're lower income through the public programs that we operate, or even as they have higher income levels, in a much more seamless way and help them be able to maintain that coverage. And there are also care delivery reforms, since I think there's a recognition that we need to, in order to have a system that is stable and is affordable moving forward, we do have to change the way that we both deliver care, focusing in on folks with multiple chronic health conditions to help them navigate their care in a better way, as well as putting different incentives in front of both providers and, I should say, clients and patients to ensure that they're seeking care in appropriate ways and that care is being delivered in ways that's effective and efficient. And all of these do have an impact on the Medicaid program, because we operate, as I just showed you, nearly 800,000 folks flowing through that program and another 100,000 flowing through Minnesota Care. There's a lot of people, and so all these changes will have an impact on the Medicaid program. Let me take just a second to talk about the exchanges. I know I'm not going to go into great depth here. I know that wasn't the committee's wishes tonight. I know that April's here from the exchange, should there be questions. But let me just briefly mention what these are. It really is intended to be a health plan marketplace for individuals, families, and small employers. And one of the things that we at Medicaid think about, though, is that a key role for the exchange moving forward, in addition to the sort of marketplace role it's going to be playing for all of Minnesota, is determining eligibility for our programs. That's something that's very explicit in the law, is that the exchange will actually be partnering with the Medicaid agencies around the country, and certainly here in Minnesota, to make the eligibility determinations on behalf of the program so that we're able to do that much more seamlessly. And the estimated usage of the exchange is about 1.3 million people coming in through the exchange by 2016. And the majority of Medicaid enrollees, about 700,000, will go through the health insurance exchange to determine their eligibility. So you can see that more than half of the initial enrollment really is Medicaid in the exchange. And that's a point I don't think folks fully understand quite yet, is how important this is going to be for Minnesota and for the Medicaid program to make sure that that is a well-functioning mechanism so that folks are able to get the coverage that they're entitled to and have through the exchange. Individuals will also be eligible to purchase coverage through the health insurance exchange with subsidies up to 400% of poverty. And so the way this is envisioned is that there's an opportunity for states to expand Medicaid up to a certain income level, and then folks above that income level will be eligible for subsidies in the exchange. I'll get to that a little bit later when I talk through some of the choices that Minnesota will have to make moving forward. The exchange will be serving a number of Minnesotans, including folks who are currently uninsured, who can apply for subsidies coverage and choose a health plan through the exchange. Medicaid, where folks can apply for coverage and choose a health plan if they're determined to be eligible by the exchange. People who want to change coverage can apply for subsidies and shop for a health plan through the exchange. And then small business owners and employees can manage their health plan choices and administer coverage via the exchange. An important thing to point out here is that Minnesota has frequently, we often talk about the Medicaid IT systems that we operate, and they're very old and they're very antiquated. They've been around for many, many years. And They are programmed in languages that we're actually having difficulty finding people to actually come and program in them anymore because they're dying off, the people who used to program in these languages. And so one of the opportunities that we're using is through the exchange to really streamline the IT platform to be shared by DHS and the exchange to enable us to get much more modern about what our systems look like so that people, as they interface with our programs, have an experience that is much more like the experience that we've all come to expect. And expect from whether it's a private sector interface or whether it's with government. And we are very much looking forward to allowing people to be able to have that experience as they shop for coverage. So now I'm going to turn and talk a little more specifically about the Affordable Care Act and Medicaid and the changes that we'll be looking at. Medicaid is a pretty significant part of the overarching goal that I think we collectively have to make sure that people are able to receive care at the appropriate place and to receive care effectively and efficiently. I've really broken up this into three kind of chunks, if you will. It's changes to the Medicaid program that are required by federal law, and I'll talk more specifically about what those are as we move forward in implementing it. What the options are around expanding Medicaid in Minnesota, and then what the new coverage options are for folks above the Medicaid expansion level should the state choose to avail itself of that option. And then there's a few other changes I'll mention at the end that relate to how we're paying for health care and program integrity as well. But first I want to talk about the changes to Medicaid that Minnesota has to implement by January 1st of 2014. And you'll be seeing a number of these changes as we come back before you with complying with what the federal law has. You'll frequently see us, not just in this case, but every year. We have some things where there have been changes to the federal law that the state needs to comply to. This will be a little bit larger than usual. So beginning in January 1st of 2014, Medicaid has new eligibility and enrollment requirements.
We have a question from Senator Kiffmeyer.
Thank you, Mr. Chairman. Just a quick question. What is the FPG dollar amount?
As always, Mr. Chair, someone would ask that question. If you can hold just a second. Do you have that information in here? Mr. Chair, Senator Kiffmeyer, it's for a household of one is about $11,000. Household of two would be about $15,000, and then you can kind of think about, so as we talk about percents of hundreds of poverty, so if you did 200, you can multiply by 2 and so forth to kind of get there from here. Thank you for asking that question. I should have had that up front a little bit sooner.
Go ahead.
So beginning in January, there's a number of things that will be required that will streamline the process and eliminate coverage gaps for individuals. So these are things that actually are good in terms of allowing folks to maintain the coverage that they're in or come into programs. They are things that when we look at the numbers, we'll enroll more people into the Medicaid program, but there'll be some costs associated with that enrollment process. There will be a new income counting method. I'll get into these more specifically. I'll just go through them here. A streamlined online application and verification processes, and an improved renewal process, as well as other eligibility changes that allow people to maintain coverage. The first one that I want to talk about is a term that you'll hear a lot of as you start to talk about the Medicaid program after 2014, and it's the new method by which states will be counting income for the purposes of determining the eligibility of individuals. It's called the Modified Adjusted Gross Income, or MAGI method, and it uses income and household information on tax returns following IRS rules to count income for Medicaid and advanced premium tax credit eligibility. This changes it somewhat from what we had in the past. So this is really matching it up more to how you report information on your tax filing. It also matches up more closely the household composition of individuals, so that folks who are counted for the purposes of Medicaid eligibility purposes will basically be the same household members and types of income that are used when you file your tax return. So it's sort of trying to harmonize a little bit better for how people have thought about this over time. As a part of this, all the asset requirements that had previously been a part of the program or any income disregards will be eliminated, and various existing income disregards will be replaced but with a single standard across the board 5% point income disregard. So what you'll see is that eligibility for individuals, oftentimes we'll talk about the expansion to Medicaid being eligible up to 133% of poverty. But with that 5% income standard disregard, it's actually up to 138% of poverty. And that's what you'll see when we talk about these things more specifically, is we'll really be talking about 138% when we talk about 133%. So these rules apply to the MAGI population, so it'd be pregnant women and infants, children, parents, and the adult expansion group, should the state choose to use that option, up to 133% of poverty. I should mention that because the rules apply to the population I just mentioned, which would be infants, kids, pregnant women, parents, and childless adults, these are the populations that we refer to as MAGI populations. The disabled and the elderly, which I showed you earlier are eligible for Medicaid, are sort of the non-MAGI populations. The ACA also requires states to implement changes related to applications, eligibility periods, and the renewal processes by which people renew for coverage. We have to be able to accept applications online. This is something that is new to us, to be able to do that. And again, that's going to be via the new system that we're building that will be shared between DHS and the exchange. But we also have to be able to accept them by mail, by fax, by phone, or in person. So I think a goal here was to be able to allow for multiple ways by which people could be able to apply for programs. And we're also required to use a new application process which emphasizes electronic verifications over paper documents. So there's a movement towards electronic in this piece of it. We also will be required to implement 12-month eligibility periods for all MAGI populations. And what that means for Minnesota is that we'll need to move from our current 6-month eligibility period to 12-month eligibility periods. This will allow people to stay on coverage longer because their determinations for their income will not occur every 6 months, but rather will happen every 12 months. And then finally, the requirements, there's also a requirement in the law around renewal that includes a requirement for an ex parte review, for which DHS must use information that we receive from a number of data sources before we ask the client for any new information. So this is a way to try to streamline that aspect of it also for individuals, so that we're using the information that's available to us rather than going back and repeatedly asking for information from individuals. A number of other changes, very briefly, that we'll be required to look at. The ACA does include a provision that expands coverage for children who are in foster care on their 18th birthday, and it's a requirement that states require or cover these children in Medicaid until their 26th birthday if they're enrolled in Medicaid on their 18th birthday. Spousal impoverishment provisions will now be applied to all individuals receiving home and community-based waiver services based on disability. And states are also required to give hospitals the option to make presumptive eligibility determinations in the Medicaid program. And what this will do is allow them to, as folks come in, ask a series of screening questions where they'll be able to make presumptive determinations prior to a final determination being made. And this will also allow them to bring folks into the program and know that they're going to be paid for the services that they deliver. And the last point I want to raise on this one relates to the maintenance of effort as it relates to children and pregnant women. And what a maintenance of effort is as laws are passed frequently, the laws that Congress occasionally will pass will require states to continue doing things that they had previously done. And they do that to sort of prevent states from cost shifting. States want to cost shift the federal government wants to prevent cost shifting from the states. Maintenance of effort means you're required to continue to do the things that you had previously done. And so in this case, we are looking at what the maintenance of effort is for children on the Medicaid program. As I mentioned earlier, children are eligible in the Minnesota Care program up to 275% of the federal poverty guideline. And our interpretation of the eligibility maintenance of effort provisions has been that Minnesota is required to maintain Medicaid eligibility for pregnant women and children aged 2 to 18 with incomes up to 275. We've been working with the CMS staff on the maintenance of effort question for some time. Very recently, CMS has shared some preliminary interpretation of the MOE that confirms our understanding that we must cover pregnant women up to 275. But they did note that we may have some options around our MOE obligations for children ages 2 to 18, but those obligations likely come with some negative funding implications. So I think our initial interpretation is that we would have to cover children up to 275. It does appear that's the case. If we want to move below that, we would have some exposure from some negative funding program in other programs. I'll next turn, Mr. Chair, and talk a little bit about the option that's in the law around Medicaid expansion. So I want to sort of categorize this first group of issues that I just went through as sort of things that we're required to do to comply, if you will, with the ACA. We're moving in now to some areas where Minnesota is going to have some decisions to make. The ACA allows states the option to expand coverage for adults with incomes below 133% or 138% with the 5% income disregard of poverty and receive matching funds in order to do that, either regular match rates or enhanced match rates. Now, in the original language of the ACA, this expansion was a mandate. But when the Supreme Court made its ruling last summer, it changed that mandate from a mandate to an option for states, saying that was coercive. This expansion group is really folks who have incomes up to 138% of poverty, who are age 19 to 65, not pregnant, aren't titled to or enrolled in Medicare, and not otherwise eligible for Medicaid. And so states have the option to expand to this population. In terms of what that group would include, it'd really be childless adults between incomes up to 133 of poverty, parents with incomes up to between 100% and 133% of poverty, because parents are currently covered up to 100% of poverty in the existing Medicaid program, and then 19 to 20-year-olds with incomes between 100 and 133% of poverty. Now, because we've had Minnesota Care in existence for the past 20 years, we actually cover a lot of these populations today. But we do it at our existing 50% match rates, and we're receiving, some of those people are enrolled in Medicaid, some of those people are enrolled in Minnesota Care, but we're receiving a 50% match to cover those individuals. We did choose, as a state, in 2011 to adopt an early expansion of the Medicaid program. And we did that again. This is back to that old GAMC population where we expanded early in advance of 2014, up to 75% of poverty for individuals at our current 50% match rate. So basically that's low-income folks with incomes below 75. We get the match rate of 50% prior to 2014. And we also receive matching funds on childless adults in our Minnesota Care program between 75% of poverty and 200% of poverty. Before I get into sort of the expansion option that's going to be before us, I also want to address something that's been a question that folks have had. There's been a lot of discussion in some states about whether or not CMS would allow states to expand coverage, but stop short of covering this new expansion group all the way up to 133% of poverty. And what we've received clarification from CMS on is that full federal funding is not available to states that don't do the full implementation. And full federal funding means 100% federal funding for this population. Therefore, in order to receive this enhanced federal match, Minnesota would have to increase our standards up to 133% of poverty. So the Medicaid expansion option, to boil it down, is really is an option for states to expand their Medicaid populations for single adult populations up to 133% of poverty at 100% federal funding. And that federal funding would be funded for the first 3 years of the program, 2014 through 2016. It does phase down a little bit over time to around 90% by 2019 and thereafter. So the match rate that a state is able to receive for this expansion population never goes below 90% and is fully federally funded for the first 3 years. There are some enrollment and budget implications should the state choose to exercise this option. When we did the early expansion to 75% of poverty at existing match rates, about 84,000 Minnesotans, including those who had been previously enrolled in either GAMC or Minnesota Care, came into Medicaid at that point. If we were to continue the expansion up to 133, we'd cover about an additional 57,000 Minnesotans, again, including some who are currently covered in Minnesota Care. Now, the key thing to think about here is the fact that as we if we were to expand those populations, a number of those individuals, or many of those individuals, are currently covered in our Minnesota Care program. And again, that's at our existing 50% federal, 50% state. We would be moving those individuals to 100% federally funded. And so there is a state budgetary savings as a result of the expansion. The combination of that early expansion and the full expansion up to 138 would save the state's budget about $1 billion between fiscal years 2011 and 2015. So as we think about kind of income limits, this is sort of the second bucket I kind of wanted to talk about, which was we had the first bucket of stuff, which is stuff we need to do to kind of comply, if you will, with the Affordable Care Act, those changes to eligibility enrollment. The second piece is the option for states to expand up to 138% of poverty at 100% FMAP, 90% by phasing down after 2016, 90% by 2020. And so you can think about kind of where we're at currently, which is what this chart looks at is our income limits for our various programs. What we have down kind of the left-hand side is the various eligibility categories. And the first column over is our current Medicaid eligibility limit for those individuals. The next column over is our current Minnesota Care income eligibility levels. And then if we were to take advantage of the option to expand Medicaid under the Affordable Care Act, you would see sort of the far right column being the new income levels. Visually, it can kind of be depicted this way. We call this our sideways spaceship picture. The yellow lines on this chart, we've broken again infants, pregnant women and children, parents and children aged 19 and 20, and adults under the age of 65. The yellow areas show our required where we would have either Medicaid requirements to cover the population because of our maintenance of effort, or have the option to expand the Medicaid program at full federal funding. So basically what you see is that for parents and adults up to 138 of poverty, the kids, because of the maintenance of effort, is up to 275% of poverty. Once you move above 138% of poverty, you start to have some options around how the state could explore that population. And I'll talk a little bit more about those in a second. But essentially it breaks down into a few options that the state can have, either through the exchange or through the operation of other new coverage opportunities.
Representative Franzen has a question.
Thank you, Mr. Chair. Mr. Lights, could you just, I'm just wondering how many currently eligible but not enrolled people do you expect to add to Medicaid? Would they be covered at the 50% match or the 100% match?
Mr. Chair and Representative Franzen, I can get you the figures as we are working forward on that. That'll be part of some of the budget discussions moving forward. So obviously that'll become things that we'll talk about moving forward with regards to the governor's budget. What I can say as it relates to sort of the matching rates and what people will come in under, when you think about that first bucket of stuff where we have people who are currently eligible for our programs under current eligibility levels, where we'll be bringing more in because we're streamlining eligibility or doing other things, that'll be at the current match rate levels. For folks who are at income, for the expansion groups, the adult population, the up to 138s, those will be at 100% federal financing for the first 3 years of the program, and then phasing down over time to 90% by 2020.
Follow-up question?
Thank you, Mr. Chair. Mr. Lights, just one last thing. Just how expensive could that be for Minnesota, or is this a conversation that we'll see later on?
Mr. Chair,
Lights.
Representative Franzen, there's offsetting impacts that occur, and will be obviously part of the discussion moving forward, but there are offsetting impacts that occur because what you have is some costs associated with bringing people who are currently eligible to the programs onto the program. The effect of the streamlining of the eligibility, for example, and the mandate will bring some additional people in who are currently eligible, and there will be a cost associated with that. Doing the Medicaid expansion does produce a savings to the state because you're moving people who are currently 50-50 funded onto fully federally funded. So there's a savings that occurs. It nets out likely to the it nets out to the positive for the state when you combine those two pieces. The exact degree to which we'll talk more about, obviously, moving forward. So you kind of have to think about it as those pieces together, but that's kind of how it works out.
Thank you.
Senator Laurie.
Yeah, but the work on eligibility in terms of streamlining and the mandate occur whether or not we expand the population, right? So those effects we assume no matter what just to come into compliance with federal law, regardless of the expansion question that we're kind of focusing on now. Is that correct?
Mr. Chair, Senator Laurie, that's correct.
Go ahead, Commissioner.
So really that leaves us with the question of if we were to do a Medicaid expansion that sort of covers folks between 138, what happens to folks who are above 133 of poverty in 2014? And so if we were to take the option of the Medicaid expansion, who would be left in the existing Minnesota Care program? That's the program that really covers folks at those higher income levels today. And what it would really be would be parents between 130.
We have another question from Representative McDonald.
Thank you, Mr. Chairman. I didn't mean to have you cut off Commissioner Lights, but thank you. Commissioner, when you said if they were currently eligible before, and now with the Affordable Care Act we'll be bringing them in, does that mean they were eligible but yet they weren't in our program?
Mr. Chair, Representative McDonald, yes, there are a number of individuals who are currently eligible for our programs who are not enrolled. One of the things I mentioned earlier, let me just step back for a second on this slide, is that we operate the Minnesota Care program under a what's called a federal 1115, section 1115 waiver. It's the section of the law that authorizes CMS to the federal agency to grant waivers to states. And that allows us to receive federal matching funds on our Minnesota Care program. What the Affordable Care Act did was to sunset all state waivers at the end of 2013, which means our Minnesota Care waiver ends at the end of 2013. So part of the discussion here is going to be how do we think about funding for folks above the 133% level who are currently served through our Minnesota Care program moving forward with the expiration of that waiver, because federal financing for those programs it's a little bit unclear at this point because of the waiver expiration. But essentially what you have are folks above 133 of poverty, up to 275, or for childless adults up to 200 or 250 of poverty, who are currently being served through Minnesota Care, and we'll need to think about what the future of that program or the options that we have available for us to determine the best action for what to do with that population above 133. And there really are a range of options for the state to consider. I mentioned earlier that the way the federal law is constructed, individuals who have incomes above Medicaid eligibility levels, in our case, if we were to do an expansion, that would be above 133 of poverty, are eligible to go into the health insurance exchange and receive subsidies to purchase coverage ranging from 2% to 9.5% of their income going to their cost. The products that will be sold in the exchange will likely carry some level of cost sharing associated with them, deductibles, co-pays, and so forth. So they would be able to purchase that coverage in the exchange with that federal subsidy. They could also go into the exchange and be, if we were concerned about the level of cost sharing, particularly for lower income people between maybe below perhaps 200% of poverty, there's an opportunity potentially to wrap around additional cost sharing and premium buy-downs for those individuals, meaning that we would sort of use state funds or some mix of federal and state funds to buy down some of the costs that are associated with this. Or we could continue to operate the Minnesota Care program, but with improvements to make the coverage better. Right now, we currently have a hospital cap at $10,000, for example, in the program. That wouldn't really comply with the federal law moving forward. And there are a number of ways we could finance the continuation of the operation of that program. One would be to use basic health plan financing. I'll get to basic health plan in a minute here. We could work with CMS to see whether we could extend the existing waiver, but that has some fiscal implications because that's at our 50% matching rate, or we could explore some hybrid with CMS. And we have been having some of those discussions with CMS around what our options are. Haven't had a lot of firm guidance to this point around that. One of the things that has been an area of a lot of discussion has been the opportunity that states have to use what's called a basic health plan option. And so let me step back for just a second, and I'm going to back up in my slides, so beware. When you look at this coverage option slide here, I'm going to focus in on the area that's between 138% of poverty and 200% of poverty. And I'm in particular going to focus it on parents and adults. And what you see is that those individuals are eligible for advanced premium tax credits in the exchange. That's sort of the purplish area on the slide. They are eligible to go at full federal funding, get coverage in the exchange with a tax credit that would allow them to purchase coverage in the exchange. States also under the law have the option, at a state option, of operating or receiving funding under what's called the basic health plan option. And that's that sort of green detached box that sits underneath the slide. And I want to talk for a few minutes about what the basic health plan option is, because I know that that's been an area of a lot of discussion and a lot of interest, not just in this state, but in a number of other states. What I'll tell you in advance of talking through this portion is that we have yet to receive a lot of guidance from the federal government around how or when or how we could operate a basic health plan option, and that's been some of the discussion that we've been having with our colleagues at the federal government around that to see whether we can explore that option a little bit further. Because what we do know is that you all are going to have to make a lot of decisions very quickly in the coming months. And we want to make sure that you have all the information you need to make those decisions. And the basic health plan option is one that we know is in the federal law, but we don't have information now to give you to help you make those options. So we're pushing hard to just get that information to you. What the basic health plan option does is it allows states to receive federal funding equal to 95% of the value of the tax credits and cost sharing reductions that the individuals would have otherwise received had they been enrolled in the health insurance exchange. It's focused on the 133 to 200% of poverty. So you think about that zone of poverty. Essentially, what it does is it says if those folks are in the exchange, their costs would be this much. You take 95% of that, give it to the state, and allow it to operate a program that it sort of designs at a state level. There's some things it needs to comply to like the essential health benefit requirements, but one of the things that we've been exploring is it could be used to provide funding for the existing Minnesota Care program that we've had in place for 20 years moving forward. It's an option that we're looking at. I know a number of other states have also been exploring this with CMS. Again, this hasn't been one, though, where they have issued guidance on the basic health plan to this point.
Commissioner Lights, could you just describe what the maintenance of effort would do for this population? Would we be locked into 50% if they were already in our program, or would we get the 95%?
We would, Mr. Chair, we would receive the 95% because essentially what we would be doing for this population is looking at the costs associated with them. Even though we do have an existing program with them, what the option at that the BHP or Basic Health Plan allows for is for us to receive funding at a 95% of what it would have cost those folks to be in the exchange, and that is the funding we would use to cover that population. So we would not be locked into the 50-50 sense that I think your question was getting at.
Oh, Senator Benson has a question.
Thank you, Mr. Chair and Mr. Lights. When is CMS going to get back to us? I mean, we have a budget to put together. We have an exchange that's due March 31st. At what point do we as a state just have to push forward and give it our best shot and ask for forgiveness rather than permission?
Mr. Chair and Senator Benson, I certainly share your concern, or your concern and your, I think, frustration at the lack of guidance that we've received so far. Commissioner Justin and I and our state Medicaid director, Carol Backstrom, did meet with the head of Medicaid federally on Friday, this past Friday, to push on that very issue. And we stressed the point that you just stressed, which is that our legislature needs to make some very difficult decisions moving forward, and they're meaningful ones. And we need guidance on this issue, and we need it by the February, frankly, by the February forecast, because you're absolutely right, are going to need to make some decisions moving forward. What we received back was a commitment to continue to work with us on the issue. They did say that they would take the issue back and look at it. We are planning to do updated phone calls in a week with them on it. But we don't have a firm commitment as to when guidance generally would be issued. I think what we're asking for is allow us to be, if this was the legislature's will, a state that could maybe, show how it could be done via this path of funding. We have an existing program that we potentially could operate, and it could be used. We could use the funding here to do that. That's an option that you should look at, frankly, as a legislature. We hope you will. And we will continue to press with the federal government on the issue. I would also say that we don't have a firm commitment, though, in terms of what the exact date to get an exact answer will be. So,
Representative Franson.
Thank you, Mr. Chair. Commissioner Lights, in essence, could the state be wasting time designing our own exchange if the federal government doesn't want to follow suit with what we have in plan?
Commissioner.
Mr. Chair and Representative Franson, I think the pieces of this fit together, and there's obviously going to be a need for the exchange because we need to have the exchange be, from a Medicaid perspective, that is our enrollment mechanism. That's how people, whether we continue to operate the Minnesota Care program or go a different direction, that is how we will enroll individuals into coverage. And there's also a need for subsidies above what our current Minnesota Care eligibility levels are, up to the 400% level, and the exchange will obviously be covering those. So I wouldn't put it that way. I think I would say that these pieces sort of they very much fit together and are part of a whole of ensuring that we have a system of coverage that's fairly seamless for individuals, regardless of the decisions that are made at the lower income levels where the Medicaid program operates.
Representative Franson has a follow-up.
Thank you, Mr. Chair. And Commissioner Lights, are there any states right now that are setting precedents for maybe veering off from the federal guidelines that we can follow suit on?
Commissioner.
Mr. Chair, Representative Franson, we'd be happy to take a look at that and see what the landscape is. I don't know right off the top of my head what other states are doing, but happy to take a look at that.
And Representative Gruenhagen gets the question. There he is.
Okay. I was trying to be bipartisan, so that's why I sat on the side. Thank you, Ms. Chair and Commissioner Leitz. On the surface, it sounds real good. There's according to what I've read, is we got over 30 states opposing the implementation of the a.c.a. right now. And you were just in Washington. Do you know why they're opposing the a.c.a.?
Mr. Chair, Representative, I can't speak for why other states are choosing to do that.
Okay. Just a couple of follow-up questions. Second thing, on the surface again, a lot of what you say sounds good, but this is what I observed, have talked to medical people and also seen, is I've seen that when we expand Medicaid with the current Medicaid reimbursement rates, and by the way, I had a doctor from my previous district come, and he was an older doctor who was still independent, and he showed me his reimbursement rates for an office visit. He got $17 for Medicaid, $34, $35 from Medicare, and $54 from private insurance. And he basically said, I lose money on Medicaid and Medicare reimbursement, and I come out okay on private insurance. He said, my problem is I'm seeing more and more Medicaid patients and less private insurance patients. So this expands that, and the result is, like in my previous district, there's an independent hospital, and now because of the a.c.a., they're consolidating. And the reason is we're seeing lower reimbursement rates, they expect, all across the system, in one of the finest healthcare systems in the world. And the result is that we're having less hospitals, and surveys show up to 30 to 40% of doctors are going to retire early or leave the profession because we're seeing these low reimbursement rates. And finally, because of these low reimbursement rates, doctors are now being coerced into being widget makers, spending only so much time with a patient and then moving to the next one. So on the surface, this sounds good, but when you look at the reality of what's happening in our healthcare system, it all points in a negative direction. So I don't see how expanding Medicaid is going to help our medical profession, and I'm all for getting everybody insured, okay? So those are some of the concerns out there I see. I'd appreciate your response.
Mr. Chair, Representative Gruenhagen, a couple thoughts in response to your questions. First, I do think you raise some valid points in the questions that you raise. I think that, first of all, I think we can all be very proud of the medical professional community here in Minnesota. Medicaid is not as high a payer as the commercial, yet we have the doctors in Minnesota actually have one of the highest participation rates in Medicaid. And I think that says a lot about sort of just the culture of the state, and hospitals do participate as well uniformly. We do think that the payment rate level is something that needs to be looked at. I think we would acknowledge that we really, for the past decade, maybe made a number of reductions to payments across the board, quite frankly. Some of that was budgetarily driven, but nevertheless, that's a concern moving forward. And for us to have a viable system, I think that's something we're going to have to look at. And that's true at a physician level. It's probably true at a hospital level and for some of the other professionals that we see. The other thing I would say is that one of the things that we're in the Medicaid program exploring, and we're the first state to actually have been approved to do this, is really starting to work more directly with providers, both through our managed care organizations and through our fee-for-service payment system that we have, to put in place incentives for them to do a lot of the things they'd like to be able to do around care coordination that they're not able to do today because the way that we pay physicians and hospitals kind of disincents them from doing that. That is to say, if they're able to, if a hospital is able to do things to save a hospitalization, that actually hurts them because they don't get the hospitalization there. So what we're working with them on are what we call our HCDS, our Healthcare Delivery System Demonstration Projects. And there's 6 large organizations that are doing this now, and one of them is actually a coalition of federally qualified health centers, and we're going to be rolling it out a little bit more broadly. And we work with them to agree on some levels of aggregate quality outcomes and aggregate expenditures on behalf of our Medicaid populations. And if they're able to actually do a great job of coordinating care, instead of the old system where they just lost money because those folks weren't showing up in the hospital, if they're able to do that and come in below sort of our mutually agreed upon targets, they actually share in that savings. And so we cut them a check at the end of the year if they're able to do that. And in that way, it starts to put the incentives in a little bit different perspective, that then they're working more collectively with us and the plans and others to try to hold down healthcare costs as well as get better outcomes in a way that still allows them to be viable in the program. So I very much appreciate your comments. I think there are some things we need to look at. That's one of the areas that we're starting down the road of, but we certainly welcome your active help on that.
Just one quick follow-up, Mr. Chair.
Go ahead.
Yeah, thank you. There's a lot of ifs, ands, or buts in that comment. And hopefully it'll all work out at the end. But, in Minnesota, the information I was given last year is that we have about 91% of all the people in Minnesota covered under some health plan. And we got 9% that aren't. And of the 9%, if memory serves me, 6% are eligible for current programs. So we're talking 3% of the population of the state of Minnesota. To me, when I look at this, and I know you're not here to answer questions about the health insurance exchange, which I have more concerns about, but we're taking a sledgehammer to drive an itty-bitty nail into the ground, okay? And I want everybody to be covered, and I want them to get the health care that they need. But it seems like it's overkill, and it's going to create more damage than benefit in the long run. Last comment, hospitals I know are buying into this just because you said, because they're going to see their charity care go down. What I caution them is to look at Massachusetts. What you save in charity care, you're going to lose in reimbursement rates. So you're not going to come out ahead. You're actually going to come out behind. And currently in Massachusetts, which is the only pilot program we have to look at in terms of the results of the a.c.a., is that they're looking at a global budget in healthcare because the costs are skyrocketing and the premiums are going through the roof. The result of global budgets in healthcare, if anybody pays attention, is rationing. And that's where we're headed with this plan, unfortunately. I think we can do better in Minnesota, and I think we should look at alternatives to compete with the a.c.a. Thank you, Mr. Chair.
We have one more question, but before we get to that, I will say, I don't know what specialty your doc was in, but the federal law will require that primary care physicians get paid at the same Medicare rate. So for the primary care docs, there'll be a boost. And then Senator Kiffmeyer has the last question, and then I would like to let Scott get on and finish.
Thank you, Mr. Chairman. Mr. Lights, Commissioner Lights, one of my questions is, one of the issues, and since this is a federal issue, that physician payments, there's been a great variation amongst the states for the same procedure. And that's been a bone of contention by many physicians who are aware of payments in other states for those same procedures. Is this addressing some of that? And Minnesota has not done well. We tend to be an efficient state, and efficiency seems to be penalized in this situation. So can you speak to what might be there as far as equalizing some of these payments across states?
Mr. Chair and Senator Kiffmeyer, you're right that there is a long-standing, and you captured it very well, inequity that has existed because we have traditionally had, and it's true upper Midwest states in general, but certainly of our state most pointedly, of an efficient healthcare system that has gotten very good quality outcomes, but has helped hold down costs. And as a result, as they built payment rate systems and payment systems that are more national through the Medicare program, efficient states like Minnesota have tended to get penalized because of that efficiency and payment rates to other areas that are less efficient, Florida being an example that gets used a lot, but other areas, Texas and others, tend to be higher and not necessarily getting the same quality outcomes. The Affordable Care Act didn't necessarily focus on those areas, but it does make some progress in a couple of areas. One is that it gave the Institute of Medicine, which is a kind of a national organization, responsibility for looking at that very issue and bringing back some recommendations. I can't claim today to know where those recommendations or what progress where that's at. But one of the things that they were asked to look at was what I believe is called the efficiency index, or I'm trying to remember the terminology for it, but it was basically trying to capture this notion that as you build payment rates, you should find a way to actually reward states, if not fully, at least make progress towards rewarding some states that do very well in their payment systems, and by looking at how effective their system is. That's obviously not been implemented yet, but it's something they were at least asked to look at as part of this. But I think the question that you raised is an important one, and I don't know that there has been as much progress on that area as we would like.
Mr. Chairman, just a comment.
Quick follow-up.
Yes, I think it's interesting that efficiency is penalized in the government reimbursement system, and but now we're going to step into even more government and a bigger role for government, and so I don't have a lot of confidence that it's going to get much better, but I just thought it's good for us to at least understand and know that we do well here in Minnesota, but we have been penalized for it. Thank you.
Commissioner Lights.
Thank you, Mr. Chair. I mentioned this earlier, but if we were to retain the Minnesota Care program, there's likely some things that we would need to modify about the program, and that particularly relates to the benefits set for childless adults and higher income parents. In particular, there's an inpatient hospital limit of $10,000 in the program. We would likely need to eliminate that. And then it's likely that the levels of deductibles and cost sharing in the existing Healthy Minnesota Contribution Program, which covers people between 200 and 250% of poverty, are likely out of compliance with the a.c.a. We need to look at that as well as some of the insurance barriers where we require people to be uninsured for 4 months before coming onto our programs. So we're looking at that issue and look forward to that discussion as well. And so I think that sums up sort of the Minnesota Care portion of this particular aspect of the presentation. Again, this is a program that I think a lot of folks have a keen interest in looking at, and at least in determining what our options are moving forward. And so to sum up our previous discussion, we will continue, I think, to have conversations with CMS, and obviously we'll keep the legislature up to date on how those are going. There are a number of other changes that relate to the a.c.a. that aren't related to eligibility or income rules. These are really around benefits, how payments are made, and what program integrity aspects we apply to the program. And so I'll just spend a few minutes talking about those. There are a number of benefit changes that are already implemented in our programs. The a.c.a. authorized payment for new services, including payments for services delivered in freestanding birth centers. We implemented this provision in October of 2010, although there weren't any birth centers licensed until January of 2011. Payments for hospice services for terminally ill kids while still allowing them to continue treatment. We implemented this program in October of 2010. And the a.c.a. also requires states to offer smoking cessation counseling services to pregnant women. We've historically offered that service as well, so that while being a requirement was something that we were already doing. There's also a change, as Mr. Chair has already mentioned, which is a physician pay bump. And what this does is require states to pay Medicare rates for certain Medicaid primary care providers for 2 years. Typically, Medicaid pays less than the Medicare program. That's traditionally been the case for most services. Not universally true, but for most services, that's true. This provision applies to both our fee-for-service program and our managed care services, and it's a fully federally funded increase that's over our existing Medicaid payment rates. It's in effect for 2 years, from January of 2013 to December of 2014, applies to primary care providers. They'll be receiving Medicare rates for the services that they receive, and again, it's fully federally funded for that differential. The a.c.a. also We're in the process of implementing this provision and still getting some guidance from CMS and clarification on the policy itself, particularly as it applies to the managed care rates. However, it takes us a little bit longer to get that guidance and finalization with CMS. The payments to the providers will be retroactive back to January, so this will occur. It's just a matter of us working through some of the things that need to be done there. We have the option of expansion of our health care homes. Law that was passed in 2008 in Minnesota allowed for the establishment of health care homes. We've been going down the path of implementing that law for the past several years. We have over 150 clinics certified as health care homes now. And what they do is are reimbursed for providing care coordination for services with people who have multiple health conditions. To allow them to be able to get better health outcomes and hopefully lower costs for the state's Medicaid program. The federal law allows us to do an expansion of that under some increased federal funding to be able to do that, with a particular emphasis on coordination of folks with physical health and mental health conditions. And so the agency is taking a look at that issue currently and looking at ways that we can better implement the mental health and coordinated care with physical health aspects of that law. Finally, the a.c.a. expanded the Medicaid drug rebate program so that states can receive rebates for drugs purchased by Medicaid managed care organizations. This provision was effective upon enactment of the bill, and to date we've collected about $85 million in refunds. Going forward, we would expect to be collecting about between $800 and $100 million per year under this provision. The last area I'll close with, Mr. Chair, just is some things related to program integrity. And this is really ensuring that we operate our programs in ways that are as free from fraud and other abuses as possible. The a.c.a. expanded the Medicare's what's called RAC program, or the Recovery Audit Contractor Program, to the Medicaid program. These are specialized teams of auditors that contract with states to look for fraud, waste, and abuse in the programs. We contracted for our RAC services in November of 2012. In addition, due to the higher potential for fraud, waste, and abuse associated with DME, or durable medical equipment, the a.c.a. now requires that clients have at least one face-to-face encounter with the prescribing physician no more than 6 months prior to the prescription for durable medical equipment. And finally, the a.c.a. tightened the exclusion policies for Medicaid. Medicaid has always been required to terminate providers who are on what's called the federal exclusion list. That requirement was broadened to require termination if Medicare has terminated, but the individual is not yet on the exclusion list, and if another state has terminated a provider from their state Medicaid program. Again, it's a provision to allow us to be able to operate our programs with integrity. So, in closing, moving forward, these are a number of things that we're looking at under the a.c.a. And these are opportunities that are in front of us. Opportunities and options around expanded coverage. We do think that this we will move down the road of streamlining applications and renewals. That's something that has been a hindrance for years within the program. There are new coverage options, particularly, and ones that for the legislature to consider, not just the expansion of Medicaid should the legislature choose to do that up to 138 of poverty, but then what do we do with that population above 138 of poverty who are now in our existing Minnesota Care program, and how does the basic health plan option fit into that? There are some new benefit packages that will be coming online, and then funding that will follow for those things. From a next steps perspective, we know that there's pressure, as Senator Benson pointed out, for us to know what our options are. And so even though we have a short time remaining, we are going to be continuing to pressing for as much federal regulation and guidance as we can. We do have ongoing discussions with between the state and Health and Human Services and CMS, and we will obviously continue and have ongoing discussions with you as those conversations progress, and tap you as we need to be a part of those. So I want to thank you for bearing with me tonight through this presentation. I know it was a lot of information, but hopefully it was useful in at least grounding you in some of the choices and discussions that you'll be having in the coming months.
Well, thank you very much, Commissioner. I think you did a fantastic job. And there'll be a time for some very brief questions. I will say that Commissioner did mention some things that are in the federal law that were modeled on what we did in Minnesota in 2008 under Governor Pawlenty when we passed the healthcare homes, chronic disease management, and an emphasis of primary care. So those things are all in the bill. And to Senator Kiffmeyer's question, I think Representative McCollum was one of the leaders in getting the federal government to at least give us a report on why Minnesota and other states like us are not getting paid as much as some other states. And lastly, before I quit, turn it over to questions. Again, this is the federal law. We have to deal with it. I'm absolutely convinced that we can do a better job here in Minnesota obeying the federal law, but doing it our way. And so we all have to be involved with this. And with that, I think Representative Gruenhagen had a question.
Oh, thank you, Mr. Chair. Real quickly, just in response to the Medicare comment about funding for primary clinics, but under the federal law, I think they're cutting out a minimum of $500 billion under Medicare reimbursement in the future. Secondly, we see hospitals and clinics all across the nation either not accepting any more Medicare patients due to this coming reduction in Medicare reimbursement, or not accepting any Medicare whatsoever. And so I think that, the idea that we're going to get Medicare reimbursement rates sounds good on the surface, but when we look at the $500 billion minimum, some say $700 billion reduction in Medicare payments, they're going to be down at the Medicaid level. The other thing I just want to throw in quickly for your response too, during a Christmas party, I met a doctor who's still independent practice here in the metro area, and he had read my book, which, by the way, I recommend you and everybody else here do. No, just kidding. So, on Amazon, yeah, right. Good read. But I had an interest. He's an older doctor, obviously. New doctors can't afford to go in business for them or set up their own practice. And one of the things he said, at least in regards to the metro area, his overhead for his office is at 35%. Okay, 35 cents of every dollar he contributes to the overhead and operation of his office, right, rather than direct medical care. He said, if I was under a hospital, and I'm open to additional information on this, he said my overhead would run 70 cents on the dollar, or 70%. So what we've done, all right, with all of this bureaucracy coming into the government through into the healthcare system through HMOs, the government, and everything else, we've created this huge expense that doesn't help the doctor-patient relationship whatsoever. And now we're going to go even one step further with the Affordable Care Act. The last comment that he gave me, he said, because he's older, he'll be retiring soon because he cannot afford to buy the technology equipment to do the type of reporting to unelected bureaucrats at a state or federal level on the Affordable Care Act. He's an excellent doctor, has built up a wonderful practice over the years. In fact, some of the people he services, by the way, or come to him, are from hospitals where they have HMO doctors who have to see so many patients. Because he's not under that, he can give them the time they need for their health condition. So, my question to you is, how is this bureaucracy we're placing onto the healthcare system, one of the best in the world, going to reduce the administrative cost with all this technology expenditure and all this reporting to people who have no business knowing what the doctor-patient is actually doing anyway? That's my opinion. If you'd like to comment on that, thank you.
Commissioner.
Mr. Chair and Representative Gruenhagen, I think you raise an important point about administrative simplification and administrative challenges that hospitals face, I think that doctors face, and that everybody in the healthcare system, I think, faces. And you're absolutely right. That's something that needs to be not just looked at, but addressed. We made some strides in Minnesota, and this was something that's been looked at nationally as a model by streamlining some of the just really behind backdoor stuff around how providers submit claims, for example, to health maintenance organizations or to insurance companies, and having that done electronically as opposed to be doing it by paper. And that has actually streamlined the system. It's an area where I think the state has collectively started to work together to try to look for ways to do that. But that can't be the end of it. I think we need to continue to look for ways to make the system a much more efficient one than it currently is from an administrative perspective, because it is very, very burdensome for folks who operate in the system.
Quick comment?
Quick.
Okay. You know, ladies and gentlemen, all of you here, whether you're Democrat, Independent, Republican, or whatever you are, this is about the future of your health care, okay, for your children and your grandchildren. And we're headed towards a rationing, heavy government-mandated bureaucracy. Please get involved. We can come up with a better solution and oppose this stuff. Let's minimize it and create a system that gets people insured, gets the care they need, but not send the information, medical information to Washington and spend billions of dollars outside the medical care industry. Thank you.
Next, we're going to have Representative Norton, but I must say that the Congressional Budget Office says that this federal law will save us money. Nobody that I know of ever criticizes the Congressional Budget Office. Representative Norton.
Thank you, Mr. Chair. Commissioner, I wondered if you could talk a little bit about how our current programs are going to interplay with this new system, and the ones, and I really appreciated your presentation, but there are some older programs, TEFRA, a.c.a, MCHO, we have all sorts of acronyms around here. How will those programs simply disappear because they're going to be covered now under, as we move into this expansion? Are these, you know, are there going to be cost savings by getting rid of some of those? And I wondered if the pre-existing condition clause will help with the ERISA programs that aren't part of our state program. So I just wonder if you could talk a little bit about some of those programs.
Sure, Mr. Chair and Representative Norton. I might ask, I don't know, April, do you want to come down on kind of MCHA stuff at all? Okay, probably not. There's commerce in the room. Anyway, as someone comes or doesn't come, and I don't know.
Doesn't look like it.
Or they can find me later and tell me.
Mr. Chairman,
Welcome.
Peter Brickwitty from the Commerce Department. I'm sorry, Representative Rowan, could you repeat the question? I'm sorry.
Thank you. Mr. Chair, thank you. I was trying to get a grip on current programs we have like TEFRA, a.c.a, MCHO. Are these programs, and TEFRA I know had a parent copay, buying into MA for children whose insurance companies didn't cover them previously. I just wondered how this all, are these programs that will disappear in the state of Minnesota, we could wipe them off the books because this will replace them? Or does the pre-existing condition clause help with some of this? I was just trying to understand our old programs and how it plays with the new.
And Mr. Chair and Representative Norton, we will address sort of the MCHO and TEFRA questions. I don't know if there's anything on the MCHA question. If there's.
Mr. Chairman and Representative Norton, I can address MCHA briefly, I think, because it's an ongoing question. MCHA is the state's high-risk pool. It services about 26,000 Minnesotans. It's a quasi-public-private board, as many of you know. The MCHA board has, with the advent of guaranteed issue, the purpose behind MCHA is going away. And so I think the question that the state is facing is where do those 26,000 individuals go so that they still receive coverage, which they're receiving quite adequately from MCHA right now. And so Commerce Department and MCHA, as well as the Governor's Office, are going to be looking at that issue this year. And so I think that is probably a long-term question, and I think the Commerce committees in both bodies are planning to take a quite detailed look at the future of MCHA.
Mr. Chair, Representative Norton, with regards to MCHO, which is a program for folks who are dually eligible for the Medicare and Medicaid programs, so these are elderly individuals but who have low incomes, That, what the federal law did was to set up what's called the Office of the Duals, if it's kind of the short term for it, because we've always had a little bit of a tension with the federal government on this issue at a state level, because Medicare is paid for federally, Medicaid is paid for mainly by, at least half by the states. And so the federal government has always had an incentive to push as many costs on the Medicaid program. We've had an incentive to try to get those folks on the Medicare side. And what we really need is some form of a way to actually have a much more blended program. And so MSHO has actually been pretty effective through the years at actually managing care for the folks who are dually eligible. We would anticipate the continuation and improvement of that program, because obviously the duals are an important part of any state's budget. They are the elderly folks who drive a fair amount of cost in the system. So, we want to improve how we manage the best pay for and manage the dually eligible population, whether that's through MSHO or other vehicles, but certainly that's an area of focus. And I might just ask Karen Gibson to come down real briefly to talk to be responded on your TEFRA question.
Welcome.
Good evening. Karen Gibson, DHS. TEFRA provides medical assistance coverage for disabled kids who have to meet certain level of care requirements without regard to parents' income. Typically in an MA eligibility determination, parents' income would be counted, and even in the Affordable Care Act with the new modified adjusted gross income methodology we discussed, we would be looking, at the tax filing unit and the parents' income and determining the child's eligibility. But with TEFRA, that's not the case. There is a parental fee that's required of the parents if they are eligible. So there probably is still a need for that TEFRA option. Some of those disabled kids are not going to meet our regular income requirements that we have, and in order for the parents to sort of maintain the coverage they need for the kids at the home, they probably are still going to need that option. So some may be able to move, but probably not. We have it today because these are higher income parents that can't provide some of the services they need for those kids.
Okay, Representative Abler.
Well, thanks, Mr. Chair. And actually, it's kind of nice to get the whole group together here. So I think that was we don't see a lot of the senators, and, that's nice they can come over here and visit us. And I hope the freshmen are enjoying the ride here with all the acronyms and the discussions. I just have two short questions. The healthy contribution, which I remember pretty well, between 200 and 250%. Is that going to continue as a carve-out, or is that just going to go to the exchange anyway?
Mr. Chair, Representative Abler, those would be individuals who would be eligible, certainly under the exchange, to receive a tax credit to purchase coverage. They're also part of the group that had been previously sort of part of the Minnesota Care eligibility. So that'll be one of the questions I think that you all have to take a look at this year.
But those people could, Mr. Chair, could keep their coverage if they like it, or they could opt, right? So they have choices.
Mr. Chair, Representative Abler, if they're in policies that are through the exchange that are ones that are equivalent to what they have.
Okay. Just one other one. The primary care increase, is that just until the end of 2014?
Mr. Chair, Representative Abler, yes, it's for 2 years.
I bet there'll be a bill on that.
Okay. Representative Loeffler, and let's try to keep it short. I would like to get out of here by 8.
Thank you, Mr. Chair, and Mr. Lights. You've done a great job of kind of going through a really complicated area. And it's sometimes hard to keep track of what's still yet to be determined, because the feds are unclear on what is clear and we're moving ahead on. And it would be nice to almost get a timeline on the things that you know about, how fast you think you'll be able to be ready, so that our partners, many of whom are represented in the audience, whether it's the physicians or the hospitals and the health plans and the counties, have some lead time as they have to adjust their systems to deal with it. But I'm also concerned about keeping the people with disabilities in the old system and the old worldview, which is not moving to MAGI and the old eligibility system, because that's kind of, to me, the old world, which is, people with disabilities aren't going to work. And we've increasingly gone to a model that when the economy recovers, I think more and more of them will be able to work. And we'll be going through that transition back and forth into employer coverage and back because we've eliminated the pre-existing condition. And I'm hoping that we're starting to think about that, particularly for that population, because I do think they're going to be a much more mobile and active in the regular marketplace than maybe sometimes old structures allowed them to be.
Commissioner.
Mr. Chair, Representative Loeffler, absolutely, and I think it extends beyond, or at least from my perspective, just the kind of coverage box that we put them in or determination of eligibility. It also gets to how we think about, as a Medicaid program, supporting disabled individuals in living a much fuller life, and we are starting to explore, as I was mentioning to Representative Gruenhagen in response to his question, models of payment with providers that will actually start to build in some incentives around encouraging them to work more closely with social services and other supports that people might need. We're starting it on the acute care side and with the more kind of more traditional populations, but I think we have a big interest in extending it to more challenging populations, disabled and others, because we think that is a way for us to get a better health outcome, probably a better quality of life outcome for those individuals, as well as likely some cost savings for the state in thinking about models that are a little bit more global that way. So I appreciate your comments, and I think we're very much thinking similarly, even beyond sort of the systems of insurance that they're in and so forth.
Representative Franson.
Thank you, Mr. Chair. Commissioner Lights, this is kind of a couple questions here, so I'll just read them. First, Representative McDonald had asked you a question about enrolling people in the expansion, and some people are not enrolled already under one of our programs. So my question is, how do you plan on enrolling people under the expansion who are eligible but not enrolled already? And then, my concern when I go back home, and I've heard it all summer long, and now that we're in session and the exchange has taken a forefront of the conversation, business owners in my district are extremely concerned about the cost that this is going to do, and my big concern is becoming a part-time nation where 30 hours is the new norm instead of 40 in order for employers to get out from under the mandate of covering their employees. And then insurance agents in my district are very concerned of being replaced and being out of a job within the next couple of years, and instead their jobs going to the navigators inside the health insurance exchange. Will you be able to guarantee that the insurance agents in the state of Minnesota will be able to keep their job and continue doing the great job that they're doing right now?
Commissioner.
Mr. Chair and Representative Franson, with regards to the first question you asked around kind of the enrollment in the expansion, we will be working very closely with the exchange. I think with our local, the MNCAs, which currently exist, which are application assistance organizations, with social service agencies and others who may come in as part of the exchange, brokers and others, to ensure that folks are getting into care when they're eligible for it. So the folks who are currently eligible but not enrolled. And I think that's just going to be an ongoing iterative process for us doing that. But we do plan to use whatever means we can available to make sure that the folks who are eligible are enrolling in our programs. So it'll be through those channels that we'll want to do that, and we'll continue. We have some efforts that are in place now, although they're not sufficient, is clearly indicated by just the fact that we do have so many people who are currently eligible but not in our programs. To your second question, obviously I think there will be a lot of discussion this year around how the exchange is structured and so forth. I can't speak to those questions. It's really an area that's not my expertise, but I know that that'll be an issue that'll be very heavily debated and likely very soon. So thank you for the question.
Senator Nelson.
Thank you, Mr. Chair. Mr. Lights, thank you for the insightful presentation. I have kind of a high-level overview question, and if it's too much for tonight, you can follow up with me later. But I understand the governor's task force recommends an active purchaser model, and I'm just a little curious why that might be, why we would want the government being the active purchaser as opposed to the passive purchaser model. What's the advantage of that? And the real nub of my question is, I'm wondering how that will shape the private market. So if we have an active purchaser model, how's that going to shape or influence the private market? And why might the governor think that's a good idea?
Commissioner.
Mr. Chair, Senator, those are ones that probably are best addressed to some of the exchange discussions, and they're actually probably best addressed to the group that actually on the task force came up with some recommendations around that area. We'd be very happy to follow up with you around what those recommendations were and how those are incorporated, I think, into various bills that are being advanced. And I'd be happy to bring that back to my colleagues at the exchange and have them follow up directly with you if that's acceptable.
Mr. Chair?
Yes.
Just a quick follow-up, please.
Sure.
Not on that issue. I'll get that later. But I did have a specific question that I think you probably are the right person to answer. This question had to do with the some of the expansion options, like the Medicaid expansion or the primary care bump. And I believe you mentioned that those have a definitive time frame where the feds are going to pay either all or partial. And I think maybe up to 90% ongoing for the expansion, but perhaps the primary care bump only for a couple of years. Right. And my question is, if we were to do the expansion, and who pays then when the feds don't? Would we be? Is there like a MOE that would take effect? So suddenly we're required to continue to offer these services, even though the federal payments cease. Would we be liable for that?
Mr. Chair, Senator, yes. I mean, let me take those in a couple of different ones. The first is you're absolutely right. So it's on the primary care rate increase, it's a 2-year increase that's fully federally funded. There's no requirement that we continue it beyond that 2-year period. So there's not anything that we're sort of getting ourselves on the hook for from a federal perspective on doing that. On the expansions, you did hear correctly that the first 3 years of the Medicaid expansion, the up to 138 of poverty expansion for single adult populations is 100% federally funded. The funding for that does phase down for the first 3 years. It's funded that way, and then it phases down over time so that by 2020 the funding is essentially 90-10, 90% federal, 10% state. If we continue to do that expansion, we would obviously need to find a 10% of our share of that match, and I'm sure that'll be something that we'll have to have some discussions about. Should the state choose to go that route, that'll be something that will need to be looked at moving forward.
Thank you, Mr. Chair.
And next we have Senator Benson.
Thank you, Mr. Chair and Mr. Lights. This is really technical, so if we need to take this offline. The MAGI requirements, there are joint filers. They're married but filing separately, and then there are individual filers. Now, for example, if someone is married, they file jointly, they have one MAGI level, but if they file separately, living at the same address, unmarried living together, is there any provision in the law that allows us to merge those addresses and then have a combined MAGI for eligibility?
Commissioner.
Mr. Chair, Senator Benson, that's a wonderful question. I'm seeing if my expert in this area has any thoughts on that, Karen Gibson, who knows more about eligibility determination than any person should be allowed to.
Thank you. We are getting much more acquainted with the tax code of late, and I have to say I don't believe that there's for households that file separately, I don't believe there's sort of a combined MAGI standard that's used. The way people file their tax is going to be how we will be using it to determine MA eligibility. In the event that people don't file taxes because some people don't meet the income filing threshold, then we will be more or less following existing MA rules that we have today. But the first step will always be to see if they're intending to file a tax return and how they're intending to file that return, and then we will be using that.
Okay, next we have Representative McDonald.
Thank you, Mr. Chairman. Commissioner Lights, I understand that to transfer from paper to digital copy is going to be a very expensive process for our hospitals. And I also understand that the money, a lot of that is being funded by the federal government as well. But how is your department handling the transferring of the digital file and the money? Where is it coming from? And then also, is that data, once that goes into a centralized system, is that still is that data still personal between the patient and the doctor, or does it come into, say, your department, and then from there is it accessed by the federal government, or is that still a private data record between myself and my doctor?
Commissioner.
Mr. Chair, Representative McDonald, just to clarify, I think what you're referring to is sort of the electronic health record, the establishment of electronic health records by providers. Is that what you're referring to? Just so I make sure I'm being responsive to your question.
Yes, Mr. Chairman. Thank you, Commissioner Lice. Yes, the the transfer of all paper files to digital files.
Mr. Chair, Representative McDonald, my understanding, the department is, doesn't directly do that work. My understanding is that providers, I believe all the hospitals now in the state and a large majority of the clinics have moved to electronic health records in their clinics to be able to more rapidly at site of care bring up information about the patient and the patient's past histories. There was a provision that was passed in, it's not actually part of the Affordable Care Act, but it was part of a previous bill that was passed by Congress that did allow for funding to hospitals and clinics to help cover some of the costs of that transfer of information into electronic health records or establishment of electronic health records. Some of that is funded, it's done primarily through the Medicare program. A little bit of it for some of the clinics that do a fair amount of Medicaid business is done through, we do provide some funding which is fully federal, which is the pass-through of the federal funding for that. All the state privacy laws with regards to medical information do apply regardless of whether it's paper or electronic in Minnesota. So I'm not an expert in that area, but I do know that that is something that has been a great deal of interest and I think cause for us to be cautious in the past, and I know that the laws do extend regardless of whether it's paper or electronic.
Follow up, Mr. Chairman. So then it's safe to say that once we implement the a.c.a. that our records will be confidential, they won't go into a central database, and they'll still be confidential between the hospitals and the patient. Is that correct?
Mr. Chair, Representative McDonald, that's certainly my understanding. Yes.
Very good. I heard otherwise. I heard that it will go into a centralized system, that our federal government will have access to all patients' records, and they'll no longer be a private transaction. But I'm glad to hear that you confirmed that that will not be the case.
I'm not aware of that, Representative.
Representative Dean.
Well, thanks for letting me back on your committee, Mr. Chair. It's good to be back, and I'm way out of shape, and I'm way behind, and I'm unprepared. So I'm trying to catch up. So your question will be very easy to answer for me because it'll be not extended far beyond what I've read in the paper recently. But it goes to an important question of the department's specific posture with CMS and how we're going to be moving forward with implementation, particularly with Minnesota's match up to 133 with respect to other states. How we are responding back to federal guidelines and what their guidance is. And as we move forward and have to become very prescriptive with the guidance that we're getting from CMS, particularly within federal match and state match, Minnesota does a great job. We do a better job than other states, but we've heard it tonight, we see it in the paper, that we don't necessarily get the benefit from that from the federal government. In much case, we get punishment for doing so. When I talk to my friends in other states and we're looking at what they're doing in terms of requirements for expansion, and I'm just going to talk about expansion and match, just very specifically. What is the department's posture in dealing with CMS, and what can we as a legislature expect from the department and from the governor in terms of backing us, in terms of trying to have Minnesota a state that continues to lead and not follow in federal health care reform? I think Chair Huntley brought up some excellent examples of where we've done that in the past. I think we've got some very prescriptive interpretations from CMS that may apply to Minnesota but may not apply to other states. And so some of us may be testing that into saying, what is that, how much of that guidance do we have to respond to as guidance, and how much of it is a guideline in moving forward, and how can we as Minnesota State in the next few months lead and not follow in the interpretation of this?
Mr. Chair and Representative Dean, I appreciate the question because I think we are equally challenged at times by the nature of our interactions with our federal partners. And I think that we have, in the discussions we've been having, particularly as it relates to the continuation of allowing us to create a system of programs that actually work for Minnesotans and are built by Minnesotans here, have really been coming from the perspective of that we certainly want to work with them, but we think we have a very unique system that has a very long history of doing very, very well by our state, and frankly, doing very well by the federal government because we keep costs low and have created a good system of care. It has been our tack with them to really talk about how we would like to continue what we've built. That in some sense, moving through the exchange for moving some people who are currently in Minnesota Care into a different coverage option may actually not be advancing them, might actually be moving us a little bit backwards or from a coverage perspective of folks who are currently covered by Minnesota Care. And so what we've been trying to work with them around is, are we able to continue the program that we operate and have operated for a long time, and work with them around what are the financing mechanisms to allow us to do that in ways that allow us to continue to be a state that's at the forefront and a state that's really leading the way around how we ensure that we have a very high quality, efficient system that gets people the coverage they need and the services that they need. So I guess I would answer your question that way, that's kind of the approach or the tack that we've been taking up to date.
Okay, Representative Franson and then Representative Liebling, and I think that would about cover the time.
Thank you, Mr. Chair. I might be one of the few here that could sit here practically all night because I do find this actually fascinating, as it's going to affect our state in a major way. My question to you is, Mr. Lights, is what happens to the people who don't agree to enroll in the Medicaid program or the Affordable Care Act? Is this where possibly the 16,000 IRS agents come into play under this?
Mr. Chair and Representative Franson, my understanding from the way the law is constructed is that starting in January of 2014, there is a requirement that folks have insurance coverage. If they do not have insurance coverage, they are subject to a penalty if they're not able to have that. And I'm not sure. There are certain exemptions that are built in around religious reasons, as well as affordability tests. That if people can demonstrate that they, on the affordability side, that the coverage is not affordable to them, or if they have a religious objection, they're not. And there's probably some others. I'm just not familiar with thinking of them right now. They wouldn't be subject to the requirement at that time. So I believe that's how the law is structured.
You have a follow-up?
Just a clarification, Mr. Chair. Commissioner Lights, I recall that you said it's a penalty. Actually, the Supreme Court ruled and said it's actually a tax. So.
Representative Liebling, last question, and then we're going to adjourn.
Well, thank you, Mr. Chair. And I don't so much have a question. I appreciate the presentation, and obviously Commissioner Lights does a great job, and especially fielding some of these questions. Very impressive. But I just wanted to kind of say, especially for people who are watching at home, perhaps, or on their computers in different places, we've heard a lot here tonight kind of challenging the Affordable Care Act and kind of going back over the old ground that, has been the fodder of campaigns. And, I mean, first of all, as Representative Huntley said, it's the law. none of us here around the table think it's perfect. I'm sure Commissioner Lights doesn't think it's perfect. But we're not talking about a perfect system versus nothing. We're talking about taking something that we've got, which is going to be a significant improvement over the old system, and trying to move it forward. So that's the posture that we're in. So when we hear certain things about, all the bureaucracy and all the, potentially rationing, we have to say, compared to what? We currently have a system with plenty of bureaucracy in it. Anybody who's had private insurance knows that. Anybody who's tried to go out and buy private insurance knows that it's awful. And so we're not now in a perfect world that's somehow going to be broken by the a.c.a. Quite the contrary. Even though we do very well in this state compared to other states, we have a system where private insurance has not worked for many, many people. The current system has not worked for many people. And the a.c.a. tries to do something which may prove to be impossible, I don't know. It tries to keep private insurance in the game and make it work for consumers. Is that really possible, to have a system of private insurance in this state or in this country and have it really work for consumers so that people actually get health care and they actually are healthy? Because after all, people don't really care about insurance. They care about getting the care they need when they need it at a price they can afford. So, if we want to talk about, there's going to be rationing and all this stuff, well, right now, if you don't have insurance, or even if you do have insurance and you can't afford the copays and so on, you are rationed. So it's not like, we might have rationing and now we don't. This is going to, hopefully, if we get it done right, is going to give everybody the opportunity to get the care they need when they need it at a price they can afford. That is the goal. And if we all kind of join hands and take a deep breath, there's stuff in here that we aren't going to like, but we have a job in front of us, and that is to make this thing work the best we can. So I hope that we can do that and kind of put the rhetoric aside, because the election is over. We got a couple years before the next one, and we got to make this thing work. So thanks to everybody.
Okay. The PowerPoint presentation from Commissioner Lights is on the House and Senate website. If you don't want to take it home with you, you can find it there, or the general public can go on there and get the website. So with that, thank you, Commissioner Lights, for doing an excellent job. And the meeting is adjourned.